Good morning, students. Today we will see the second part of motor cortex. So in this class, we will see about the descending tracts. So the classification of descending pathways, corticospinal tract, its origin, course, termination and functions. So this corticospinal tract is very important. So this will come as essay question, and from this short questions may come, MCQs may come. So this is very important stock question. And then human paralysis, that is upper motor neuron paralysis. So now the descending motor pathways, we have two classifications. One is clinical and physiological. So these motor pathways, descending motor pathways means the pathways which start from the above, that is the higher centers, brain, cerebral cortex or brainstem. So they start from the above and end in the spinal cord motor neurons. So these descending tracts are all not motor because some tracts are also having sensory functions. So major are the motor tracts. And these clinical classification we have traditionally categorized into pyramidal and extrapyramidal tracts. So why these are pyramidal and extrapyramidal means in the medulla we have a structure called pyramid. So the tracts which pass through the pyramid are called pyramidal and which do not pass are called extrapyramidal. But why the confusion is present between these two, and this why this classification is not appropriate means not all the fibers of pyramidal tract pass through the pyramid. Some fibers in the anterior corticospinal tract bypass the pyramid. And also the signs seen in patients suffering from pyramidal tract disease are not similar to features of isolated lesion of corticospinal tract seen in experimental animals. And also the extrapyramidal fibers do not pass through the pyramid, but because the tracts originate from the brainstem, the major descending pathway involved in basal ganglia function is corticospinal rather than extrapyramidal. So some confusion is there between the pyramidal and extrapyramidal tract classification. So the appropriate or uh, correct classification will be the physiological classification. So this classification is based on the termination of pathways on motor neurons in spinal cord and their positioning in the spinal cord. So we can categorize them into lateral and medial system pathways. In the lateral system, the pathways that descend down in the lateral column of spinal cord, which include lateral corticospinal and retrospinal tract. So the fibers terminate on the motor neurons that are placed laterally on the ventral horn of spinal cord. And these tracts are involved in regulation of skilled voluntary movements. And other system is medial system. So the fibers that descend down in the medial and anterior column of the spinal cord. And the pathways are anterior corticospinal, reticulospinal, vestibulospinal and tectospinal tracts. So these fibers terminate on the motor neurons that are placed medially in the ventral horn, that is medial group of motor neurons. And these tracts are involved in maintenance or regulation of posture of the person. So see here, these are the lateral group of motor neurons. The tracts which end in the lateral group are the lateral descending pathways. And this picture is the medial descending pathways, the medial group of motor neurons, and the tracts which end in the medial group of motor neurons are the anterior corticospinal, and this is tectospinal, reticulo and vestibulo. And these are the various tracts which descend from the cortex and midbrain structures. So the first one is the corticospinal, and this is tectospinal. In the midbrain there is superior colliculus. SC is superior colliculus, the tectospinal tract, and RN is a red nucleus, and this is also in midbrain. This is the retrospinal tract, and in the pons it is there is vestibular nucleus. This is vestibulospinal tract, and these are the reticulo. This is vestibulospinal, and these are reticulospinal. This is RFP means reticular formation of pons, and this is reticular formation of medulla. And the criteria to describe any tract, we have these headings. The first, synonyms or any synonym name for that tract, and the origin of the tract, course, crossing, is there any crossing in the pathway, and the termination and functions, and applied physiology. So in this picture, as you can see, in this picture, these are the sections of the brain, the cerebral cortex and the medulla, and this is spinal cord. This is also spinal cord section. So the pathway is shown taking these sections, and the fibers are starting from the cerebral cortex motor area, and then they are passing through the pyramid, and some are not passing. The pyramid is present here and here. So these fibers are not passing through the pyramid, and then finally ending in the medial and lateral group of motor neurons, and finally supplying the skeletal muscle. So this is the origin, and this is the course, and crossing is present here. So this is crossing from this side, it is crossing to the opposite side, and termination is the neurons. And what is the function of this tract, and any applied physiology, that is any lesion in this tract, in this pathway producing clinical symptoms, clinical diseases, that is the applied physiology. So the pyramidal tract or corticospinal tract. So this is the corticospinal tract, the axons arising from the cortex and descending down to the spinal cord. These are the corticospinal, or otherwise called pyramidal tracts, or otherwise also called upper motor neurons. Okay, so these tracts are divided into two parts. One is lateral tract and other is anterior or ventral corticospinal tract. So lateral tract constitutes to 80% of fibers in the corticospinal pathway. So this is the most important. Lateral tract is the most important, and anterior tract constitutes only 20% of fibers. And anterior is involved in posture regulation, and lateral is involved in skilled voluntary movements of the individual. And the origin is from primary motor cortex 30%, and premotor area 30%, and somatosensory area 40%. So some part 40% is also arising from the sensory cortex. So these fibers are originating from the major part is 30% primary motor cortex from the large cells of beds in the fifth layer of precentral gyrus. And so the motor cortex is contributing totally to 60% of fibers, and sensory is contributing to 40% of fibers. So this is a total picture of corticospinal tract. So in this, the motor cortex and other cortical areas are shown. The fibers are starting, and then in the pyramid they are crossing to the opposite side. This is the lateral corticospinal. The fibers which are not crossing are the anterior corticospinal tract fibers. So they are ending in the spinal cord neurons and supplying the so see here the lateral tract fibers are supplying the distal group. These are involved in skilled movement, and anterior tract fibers So anterior tract fibers are also crossing to the opposite side in the lower level, spinal cord level. So these are supplying the proximal group of muscles which maintain the posture. So this diagram is very important. You should draw this in the exam when the question comes. So course and termination from the cortex. From cortex, the fibers descend down as a part of corona radiata. Corona radiata means the fibers in subcortical areas appearing in the radiating pattern, appearing as a corona radiata. They pass through the posterior limb of internal capsule and in the brainstem. So they pass through the pyramidal structure, that is the, here you can see the pyramid in the medulla, and 80% of fibers after passing through the pyramid immediately decussate. Okay, so immediately decussate, that is cross over to the opposite side and descend down in the lateral funiculus of spinal cord, which forms the lateral corticospinal tract, and the remaining 20% fibers descend down the same side in the anterior part of the spinal cord, and these are the anterior or ventral corticospinal tract. Okay, so the pink colored one is the anterior and the blue colored one is the lateral corticospinal tract. So the anterior tract fibers cross over to the opposite side only at the spinal cord segment. The lateral corticospinal tract, again, it constitutes the 80% of fibers and they terminate on interneurons or ventral horn cells, which forms the upper motor neurons. From the ventral horn cells to the skeletal muscles, these are called the lower motor neurons. Okay, so here these are the, from here cortex to the spinal cord, these are the upper motor neurons, and from the anterior horn cell to the skeletal muscle, these are the lower motor neurons. An anterior corticospinal tract constitutes to 20% of the uncrossed fibers and they descend in the anterior white funiculus only up to the mid-thoracic region. Then in the spinal cord crosses to the opposite side and terminates on the ventral horn cells. So thus cortex on one side connected to the ventral horn cells on the opposite side. The features or salient features of the corticospinal tract are these fibers are unmyelinated at birth. So the myelination begins in second postnatal week and completed by 2 years. And the 80% of these fibers are small and 20% are large diameter fibers. Large diameter fibers disappears at old age and which causes automatic shaking movements of hands. Okay, so these points are very important. So this will come as MCQs. And the functions of this corticospinal tract are they control voluntary fine skill movements and they are closely packed in the internal capsule and brainstem. So any small lesion causes widespread paralysis of the individual. They send collaterals to basal ganglia, cerebellum for coordination of movements. Okay, so in this picture you can see the fibers are passing through the posterior limb of internal capsule. So they are closely packed in this internal capsule area. So any small lesion here causes widespread because the fibers are converging from the cortex. All the fibers, they are closely packed together in this small area of internal capsule and then again they are spreading out. Okay. So if there is any lesion major, almost all the fibers of corticospinal tract are damaged so that the paralysis will be very widespread. So before going into the applied aspects, so just have a brief summary of the major descending tracts of the spinal cord. So in today's class, morning class, we are seeing only the corticospinal tract, that is the lateral and anterior corticospinal tract. So these are located in the lateral column of the spinal cord and anterior column of the spinal cord, origin and then termination and the functions. Okay, so these are the extrapyramidal tracts which we will see in the afternoon class. So the lesion of corticospinal tract at the internal capsule is the most common lesion of corticospinal tract. So because in the previous slide, in the picture I have shown, the internal capsule, it is very narrow part. So any minor lesion will cause widespread paralysis. So this is often termed as complete upper motor neuron paralysis. And the features of this corticospinal tract lesion at the internal capsule, it is also called capsular lesion. The features are contralateral hemiplegia. This word is very, very important. So this contralateral means opposite side. Okay, suppose the tract involved is right side tract. Okay, but the features seen in the paralyzed individual will be on left side. Why opposite side means the fibers are crossing. The lateral tract fibers are crossing at the pyramid and the anterior tract fibers are crossing at the spinal cord. So anyhow, at anywhere, the fibers originating from right side are crossing to the opposite side. So that's why the features are seen on the opposite side of the body. The lesion involved will be, suppose, on the right side, the features seen are on the left side. So this is contralateral hemiplegia. Okay, and the cause for this paralysis or the lesion at the internal capsule is most common cause rupture of Charcot's artery. This artery is a branch of middle cerebral artery. Okay, so the brain's artery, cerebral arteries, that to middle cerebral artery, its branch, one of its branch is named as Charcot's artery. So this Charcot's artery rupture is the main culprit or cause for the lesion at internal capsule. Okay, so this is termed as upper motor neuron paralysis and the features are contralateral hemiplegia and the cause is Charcot's artery rupture. And some features of upper motor neuron paralysis are increased muscle tone, that is spasticity, and atrophy of the muscle, that is muscle degradation. If we don't use the muscle will be atrophied. So that will not be present. And the muscles affected are usually in groups. Tendon reflexes like knee jerk, ankle jerk, biceps. So these deep tendon reflexes are exaggerated. That is higher. The response will be increased, highly increased. And superficial reflexes like abdominal, plantar, corneal, those reflexes are lost. And Babinski sign is positive. So this Babinski sign is the normal flexor response is seen when we give a plantar, when we elicit a plantar reflex. But the Babinski sign positive means the fingers, the plantar response is not, flexor response is not seen, and there will be extensor plantar response. Okay. So the Babinski sign or extensor plantar response. Corticospinal tract normally excites the flexor motor neurons and inhibits the extensor motor neurons supplying the muscles of digits of limb. So it applies to any muscle. So it excites the flexor and inhibits the extensor. So normally if the corticospinal tract is activated, it should cause flexion movement. Okay. So normally stroking of foot elicits plantar flexion. But what happens in upper motor neuron paralysis? Disruption of corticospinal tract influences on the lumbosacral motor neurons, causes dorsiflexion of great toe and fanning of other toes. Okay, so only one great toe will be flexed to above and the other toes will be fanned, that is expanded. So this response is called extensor plantar response or Babinski sign positive. So this is seen in upper motor neuron paralysis and also in newborns. Okay, you can see here the test is done here like this. plantar reflex. With the help of a pointed object, if we stroke over the lateral area of the sole coming towards the great toe. So in this way, if we give a stroke, the response normally seen is flexion, plantar flexion. All the toes will be flexed. Okay, so you can try this at your home. So this is not negative, Babinski sign negative. This is the normal response. And when it is called positive means when there is dorsiflexion of great toe, that is the great toe is flexed above towards the upper side, dorsal side, and the other toes are being expanded. Okay, this is fanning of other toes. So this response is Babinski sign positive, and this is seen in upper motor neuron lesion. So to summarize, we have seen in today's class the tracts, descending motor pathways, the clinical and physiological classifications. In clinical, we have seen the pyramidal and extrapyramidal. So what are the pyramidal and extrapyramidal tracts? So pyramidal is the only corticospinal and remaining other are extrapyramidal. And physiological, we have two systems, lateral and medial. In lateral, we have lateral corticospinal and rubrospinal, and remaining four in the medial group. So these classifications are very important, and the pyramidal tract we have seen in detail. So this will come as an essay question for you. This is very important stock question. Okay, so draw the diagram and write down the origin, course, and the crossing at termination, functions, and applied physiology of corticospinal tract. So take this as assignment and submit to me in the Telegram. Thank you all.